Thanks very much. This is a tricky field because there's an awful lot of hard work involved in monitoring, being vigilant about the risks to the patients from the treatments we use. And it's not very publishable either. Like we have published it, and that's not a bad sort of reference for our philosophy. But it's not very publishable. It's more physicianly work, and so it's sort of an honour to give this at the college and to, at the same time, be part of this meeting, which is called At the Limits, but I'm probably going to push them a bit, although I suspect that's intended. So many of you ask, why do we manage the pharmacovigilance burden? It's to reduce the risk, right? How do you do it? Well, I think the short answer is many of you will take the attitude that we can't properly, right? And that often we don't bother, right? And certainly where I learnt neuroimmunology from a really fantastic mainly peripheral, but also MS neuroimmunologist, you know, the one thing I took away from my training in that clinic was that the patients did well from their disease, but they did terribly from the side effects of the treatments being used. They all had steroid-induced osteoporosis. Many of them got skin cancer and lymphoma. And that was one of the things I set up my clinic to do, was to not only treat patients well, but to minimise the risks. And so, although the physician dictum is first do no harm, we know that's unrealistic with most highly active drugs for dangerous diseases. You know, think of adjuvant chemotherapy for breast cancer, right? You are going to do harm. The trick is, therefore, to in the main do no harm and have a bloody good discussion about the risks that you're taking. Right? So lots of disclosures, and in particular I'll point out I do have equity in something that gets money from some of these systems, right? So why manage the risk? And that's whether or not the risk is in the product information. Right, so one of the things I'm going to criticise is the way product informations are put together, and I think they are deficient by design. And so it's because at the end of the day, the treatments you have produce a set benefit that's largely defined by the trials. And then the best way that you can improve things in a way is to either minimise the ratio of the benefit to the risk or the absolute benefit to the risk. Now, both the benefit and the risk can be influenced by who you give the treatment to, right? And who's at risk of benefit, who's at risk of harm. The dose, which is a major failing of our current system, right? So alemtuzumab is 12 milligrams. Why? Right? Natalizumab is 300 milligrams per month. Why? And we've started to bend that. Okay. If the only dose of prednisone was methylprednisone 100 milligram tablets, how would I treat myasthenia? Right? So unfortunately, the concurrence of regulators and pharma has meant that we have fixed doses for approved products and unfixed doses for the traditional products, which doesn't actually make sense. And then monitoring both for effect, so MRIs, and for risks. So there's obviously frequency and value weighting aspects to the risks that occur. And the other thing is that I think this is not for everybody. You need to have the skill and capacity and clinical size and depth of cover to manage what goes from being a risk of something bad to being really something bad, because that's your opportunity to actually forestall a catastrophic or irreversible outcome. So, you know, to turn ITP from a treatable disease to fatal hemorrhage. So every time I give this talk, I always feel that I'm a complete downer. You know, I should put on a ghoul mask and do this at Halloween, because the reality is I actually one of the most aggressive treaters of all of the diseases, and particularly, you know, MS is a bad disease. Right? So it's not to say don't treat, it's just to be aware. And the problem is, you know, you get these drug warnings, which are classically called a black box, but here it's red. And this is a 1 in 1,000 risk. And the concern is that it's hard to see and that many of you will not see one. Right? But the confluence of 1 in 1,000 risk is there's lots of different infections and there's lots of different cancers. Right? The confluence of those risks in a clinic adds up, and each year it adds up. And so once you've been doing these clinics for 10 years, you do see these problems. And so we need to have ways to offset that where we can, or at least to know about it. Right. When I was training, we really didn't think about the risks. I think natalizumab changed that. I think PML changed that. We started to accept that 1 in 1,000 risks per year, right, mattered. But we're still very inconsistent about that, and we ignore much more frequent risks of harm. You know, the number needed to harm for corticosteroids is a lot less than 1 in 1,000. Right. So you care about PML, but so many people still treat for 24 months. Why is that? Right, for a JC positive patient, why is that? The risk in the first year is about 2 per 100,000. Right. The risk in the second year is about 1 per 1,000. The risk in the third year is about 2 per 1,000 if you're JC positive. So why is it okay to treat up to 24 months and have a 1 in 1,000 risk in the second year? You double that risk in the third year and people stop treating. But it's fine to go from the first year to the second year where you go up 50-fold. I don't understand that. Simply don't. It's inconsistent. It's lacking in numeric integrity. So we know about VZV, Alistair mentioned, you know, fatal primary zoster, primary chickenpox. Right? So there were 3 cases of primary zoster in Clarity, Gavin, right? None fatal, which was good. But as a result, the product information for cladribine, in Australia at least, has checked for VZV and vaccinated if negative. Right? We know there have been fatal cases of primary varicella with azathioprine, mycophenolate, methotrexate, cyclosporin, all the traditional drugs. Right? So why is it that we don't regard this as a class effect? So the product information for Ocrevus does not have check for varicella zoster. Right? So there's this lack of consistency about known class problems, right, that Alistair's already alluded to. But we don't write the product informations on a class basis because they're reactive rather than prospective or future thinking or what's called a future hazards analysis, because we wait until people die, right, which is unwise. So there are other areas of medicine where they have managed to show that simple interventions, widely applied, can substantially reduce risk. This is maternal mortality. I apologise for showing this to the women in the room because it's bloody scary. Right? So the mortality roughly ticked along at about 1,000 per 100,000 births, right? 1 in 100, right? Until hygiene, Semmelweis and their antibiotics, slight blip up for war, blood products, postpartum hemorrhage, blood pressure control, and it's now down to 10, right, so 100-fold reduction in 100 years, 2 logarithms, right? It's continuing to come down, but more slowly. So that's simple stuff, right? The immunosuppression screen is simple stuff, but we don't do it well because of what's called human factors. We forget stuff, right? And until you put in place systems, and the best classic symptom, and this has been talked about by, you know, surgeons, etc., is checklists, right? Just because they remind us. So can I ask, who here reliably remembers to check hepatitis B core antibody, right, before starting somebody on Ocrevus every time? Who reliably does that? And who may have forgotten on occasions? Nobody. It's fantastic. I'm very pleased. Right? That's much better than Australia, right? Because there was a study of rituximab off-label, right, for autoimmunity in Australia, about 500 patients. And it's known, it's in the product information to check for hepatitis B, including core antibody, right? And 46% were inadequately screened, and there was 1 fatality, right? And I suspect in Australia, even though not here, right, that is still occurring with Ocrevus because there is no systematic checklist, right? There's instructions in the PI on page 7 if you read it, right? But there is no systematic checklist. Now, we've argued and indeed made commercial approaches to put in place a monitoring system akin to what we'll talk about later, which have not yet been taken up. But I think there should be systematic approaches to screening for the known identified risks of drugs before you go on them and not just after. Right? So it's called human factors. And if you want to do things well, you have to decide what it is you're doing. You have to make it simple, but you have to make it systematic. You have to put in place a process And you need to have that process knowing that it's done. Right? And that does not work with paper files where it's all buried in there somewhere and it's hard to find. Right? So remember I said we set up our clinic to be good at neuroimmunology but safe, and we were awful when we did our own audit. Right? We were really bad because we weren't systematic, even though we wanted to be. Right? So I'm much worse than you guys. So we found that, in fact, we hadn't screened properly for hepatitis B. We'd often done surface antigen, but not surface antibody, or at least not core antibody. We had terrible vaccination certainty. A lot of them had had their vaccines, but we just hadn't confirmed that they'd had them. Right? And so we came up with an approach which is based upon really checklist systems, right? Which is that risk management's boring, so try and get somebody else to do it, or try and get something else to do it, right? And that means offloading it to people who can do it, much more readily in a systematic way, and preferably in a somewhat automated way. So this is, in 1890, 70% of the US population was employed farming, right? 70%. And it's now down to about 0.7% because of automation, really, and machinery. So that's exactly what Alistair introduced, right? We put it together. It's old. It's rough. It's not slick. It's not commercial, right? Doesn't have any commercial backing. And the philosophy is the lifetime, right? So exactly as Alistair said, do this when they're starting, not when they need the drug, right? And it considers 6 factors. Cardiovascular risk, huge. It's amazing how many people you've forgotten to ask if they smoke. And we heard yesterday how important that is both for cardiovascular risk. And remember, if we save these people from dying from MS, which I think our treatments will, right, then they're going to die of something else. Right? And that was exactly what I saw when I was the HIV registrar the year Heart came in. So we said, congratulations, you're going to live now. Right? But now you're going to have to stop smoking and go on a health kick because you'll die of something else. So cardiovascular risk, infections, which are very important, vaccination status we've just discussed, cancer risk, I'm going to disagree with Alistair and say there's no doubt that immunosuppression is associated with cancer. And fertility and breastfeeding is in there because it's a good cross-check, something we forget. And corticosteroid risk management, which is important for MS and not as important as other neuroimmunology. Here's an example, patient with myasthenia, bad, thymoma, getting weak, lots of bulbar dysfunction, deteriorating despite routine therapy. So our drug of choice in that instance is actually cyclophosphamide. We screened him. He turned out to be not only active Hep B, but in fact he had quantiferon gold positive tuberculosis. I disagree with the idea of population screening based on best guess of who they are. It's a classic fail for HIV testing, for instance. Right? It's also a classic fail because everybody's travelled these days. Everybody's been somewhere where there's TB, and we do pick up people from Caucasian backgrounds of TB exposure. Including myself. I've got positive quantiferon gold. I grew up in Malaysia at one stage. Right? So, and you get an output like that. There's no privacy involved because we don't ask names, we don't keep any data. So if you want to go back and find out what data you put in before, we don't have it. And you get a list of suggested tasks. Here's what we treated this patient with, some entecavir, some isoniazid. These days, by the way, you'd use rifampicin. There was a New England Journal trial last year that showed rifampacin's just as good and safer. And his myasthenia is great. There are areas of life that are much more systematic about safety. Aviation is one of them. This is what's called a tail strike test, right? This is a fantastic opportunity for flight test engineers to take photos in dusk, right? Because it looks really good when you fly a plane and you rotate it to take off, but you're flying at a speed that does not generate enough lift off the wings that you do take off. So you rub your ass on the ground, basically, right? And what you do, if you're testing this, is you put a sort of mahogany block with an iron ferrule underneath it to produce pretty sparks, right? And why would a plane do that? Well, it's very simple. This is exactly what happened. In fact, it happened in Melbourne last year on a flight to Bangkok, right? Was the load was incorrectly calculated and the person made a digit transcription. So instead of taking off at 350 tonnes, the takeoff weight was 250 tonnes. The first flight officer, that's the registrar, the junior person, right, was a bit inexperienced, didn't really think that was, whoops, this is just not the right weight for a flight to Bangkok, right? The captain didn't properly check it because they were distracted at the time by the hostie, vis-a-vis the nurse who was asking them something, right? And so they rotated at the correct takeoff speed for 250-ton 777 and ground their ass across the lights at the end of the runway at Melbourne. Fortunately, they got off the ground, right, by putting in more thrust. But the same thing happens in medicine, right? Because we're distracted because of what are called human factors. And so there's actually this big body of safety theory that talks about this. And it's one of the principal concepts is this Swiss cheese model, right? That true disasters are rarely a single failure, right? They're usually multiple failures because we're good enough that we at least have systems to prevent true disasters, right? So it's when everything lines up, right? And so we applied this to alemtuzumab and said, look, there is a real risk of ITP. It's about 2%. It's the same with AHSCT. All the studies with AHSCT with more than 50 people have had at least one ITP. So you have a patient who's had their alemtuzumab. Bad luck, they get ITP, right? They don't recognise the skin features or they don't occur, right, before they have a risk of a fatal hemorrhage, right? So for some reason, the full blood count is not done, the patient's slack, or it's not seen by the doctor because they're travelling, or they forget about it because they're distracted by the hostess, right? And so your last chance is here. And what safety systems says is don't put in place another layer of the same thing, right? Don't put in place another nurse, right? Because all the nurses and doctors go on holidays at Christmas. Put in place something different that has different failure points. So what we said is put in place a computer system because computers are really dumb. They make lots of really stupid errors, but they're very systematic and they don't take Christmas holidays. Right? And so we put in place an automated system that takes the patient's pathology, which goes normally to the neurologist, and we do not interfere in normal patient care. But we take an electronic carbon copy, right, and we send out the scheduled and the reminders. And if they're late, we not only remind the patient, but their mother or whoever they delegate to hassle them. And it works really well, right, having your mother hassle for you, because we save so much money and we don't have to pay the mother, right? And then if there's an alert, it goes to the neurologist and the delegate. And it really works in practice. Like, I didn't actually set this up to occur, right? But actually, the first ITP in one of my patients, who's such a high-level lawyer that she could sue everything I have off me, right? Got ITP. And 77 was the first count, but actually she got real ITP. Right? And I was in Munich. Right? And I had acknowledged the alert within 48 minutes of it going out from the computer system in Australia. We have the timestamps. And I rang my colleague in Sydney and said, please, can you sort this VIP out? Right? And it's all sorted out. And when I got back, another of my colleagues took this photo. And in the middle of that pile is the pathology result, right, that nobody had looked at because I was on holiday, plus the additional facts from the pathology company that said, did you know you have a critically low platelet count, which also nobody had looked at. Right? So the system works as intended. And we've commercialised that. So we rolled it out across Australia. We get paid to do it. We've now rolled it out largely across the US. I have a commercial conflict of interest. We're still not yet, although we have hopes, and we've applied to a number of the other companies who I think need a pre-screen, been able to convince people to put in place a systematic pre-screen for some of these drugs as well. But we live in hope. So aviation safety, which is, I think, where we should be at, has really three major concepts. The historic aspect, which is investigating past accidents, ITP, right, and putting in place a management structure to resolve that, right? It's also about diagnostic aspects, which is putting in place adverse event reporting forms, right, what are called near misses, right, to try and develop a picture before a near miss becomes a real accident. And we're not good at adverse event reporting in medicine. And then prognostic, which is both class effects and also, which we're not good at, and I've mentioned the product information inconsistency, and also what's called a future hazards analysis, which is bright people getting in a room and saying, listen, we're doing this to the lymphocytes, David, could you come and be on a committee and discuss exactly what it is that we should think that we should be concerned about so we can put in place a post-authorization safety study that specifically looks carefully at those aspects, which we're not doing. Right? So, reporting, diagnostic. In 2010, there was a bad batch of IVIG from Opta that had 2 fatalities and a whole bunch of clots. But in fact, there were at least 4 fatalities because there were 2 in Sydney that didn't get reported, including one of mine. I mean, subsequently got reported, but it never got included in the initial reports. And the reason for that was, well, we knew that clots happen with IVIG. We just didn't know it was this batch, right? And I actually did want to report it, but they sent me this, right? And that is an hour, and I had to get my tax done, and the tax office will fine me if they don't do my tax, but Opta's not going to fine me if I don't do this, right? And so it didn't get done till a long while afterwards, right? Because it is punitive. This is a punitive response to daring to report an adverse event, right? And so if you think about it, there should be a system that encourages adverse event reporting. Gavin, do they still have Ash Cash in the UK? So Ash Cash is the $40 that a resident gets for filling in the cremation certificate. Right? This should be Dash Cash or something like that. Right? So serious incident reporting is failure. It's very poorly done. It's not systematic. It's not supported. It's punitive to people who want to do it, right? Because it takes time away from our other occupations. There's little or no feedback. We almost never get anything other than a yes, your report has been noted. Right. We don't really know who's working in the regulator looking at this, and we don't know if the regulator's doing a good job. A lot of it's devolved to industry, which I think is inappropriate. I mean, we've just had massive banking royal commissions in Australia that have shown what happens when regulation gets devolved to banking industry, right? And at least at a hospital level, right, it's more about bureaucratic key performance indicators than actually trying to identify and fix a safety signal. A little caution about reporting limitations. So there's a fairly clear signal for a low increase rate of melanoma with immunosuppression. Right? Rheumatoid arthritis, quote unquote, fairly big numbers, very big numbers, although actually not that many years of treatment, right? You need many years of treatment to generate cancer, right? Did not confirm an overall increased risk of melanoma following exposure to TNF inhibitors, right? But look at the data. Okay, first of all, no increase. I think if you're at 0.99 confidence interval, you should say no statistically significant increase rather than just no increase. I think that's somewhat disingenuous language. Secondly, the only 2 studies that really showed an increase, and one was statistically significant, were the 2 studies where the disease and the treatment were linked to a specific cancer registry. Right? Everything else was reporting from clinics or clinic registries, and it's when you get the cancer that you don't go back to the clinic, you don't get put into MS base, and you fail to report the event. Right? So if you want to construct a system that is going to give you ideally an incorrectly low rate of reporting of malignancy, you construct it based upon things like registries, right? Which unfortunately is kind of what's being done as the solution to passes for all the drugs other than alemtuzumab. So the pharma are now working with the registries to develop pass studies, which I support because I think some data is better than none. But unless they are either specifically linked with the Danish and Swedish to the cancer registries, or unless you fund them properly, such as MS Base, which are not funded properly, to do actual case reporting and case finding. So if a person does not come back, you find them and you find if they've had a cancer. That is the only way to actually get a true representation. Right? So we're going to do this, and it's disappointing to me that other than alemtuzumab, none of the studies have really had a proper pass, right? Looking for these long-term consequences. And why is that? Because 2-year data does not equal malignancy risk, right? And the reason for that, we know that there's an immunosuppression-associated malignancy. Look at the date, 1972. Right. It actually goes back to Macfarlane Burnett, 1962, in the British Medical Journal, who first published this. Right. So what they used to call reticulum cell sarcoma is in fact just non-Hodgkin's outside of lymph nodes. Right. Okay. Look at the other cancers that are occurring: leiomyosarcomas, Kaposi's sarcoma, and 28 other tumours: cervix, lip, skin. Look at those particular types. Right. British Medical Journal, 1972. Right? Really confirmed in a huge study by Grulich, right? Lancet, there. But 8-year follow-up, 7-year follow-up, 400,000 and 30,000. Right? It does not matter how you get your immunodeficiency, be it by HIV or iatrogenic transplant with drug. Right? Immunosuppression is substantially associated, particularly with cancers driven by infections, lymphomas, Kaposi's, more in HIV, but 100-fold in transplant. No particular sexual risk associated with needing a kidney transplant. Right? Hepatitis, which we're not going to see in the Swedish registries. Right? We're going to see in Asia. We'll probably see nasopharyngeal carcinoma in Asia too from EBV. Helicobacter, nobody thinks about that. Substantial rises in cervical, other genitals, so penile, anal, right? Skin, esophageal, even lung cancer. But what you don't see is increase in the major solid organ cancers, breast, bowel, prostate, pancreas, in fact, because they're not actually probably virally driven. Right? So the other point is that the doubling rate of most cancers is greater than 30 days. So even if the oncogenic event occurs on day one, so Alistair gives his alemtuzumab and suddenly there's an oncogenic event in a cell, right? Unless it's something like Burkitt's lymphoma, which has an incredibly high doubling rate, and one did occur in it, one of the studies, right? You're not going to see it in 2 years, right? So breast cancer in Ocrevus is almost certainly irrelevant, but it features in the product information. What doesn't feature in the product information in LIGHTS is the anaplastic lymphoma that occurred with Ocrevus. Right? But that probably is relevant. Anaplastic lymphoma doesn't have CD20, which is why CHOP-R doesn't work very well for it. Right? So just be aware of this, right? Probably the only standard solid organ cancer that has a doubling rate under 30 days is small cell lung cancer. Right? All the others, it's just a biological implausibility that you're going to see it in a 2-year study. Right? So what does that mean about fingolimod? And I'm picking on fingolimod because there's a lot of it and it's been around for the longest, but the others will have problems, particularly the chronic therapies. Right? This may be an advantage of alemtuzumab, transplant, possibly cladribine, depending on how it goes long term. Right? So remember, fingolimod's a transplant drug originally, right? Repurposed because it didn't do so well. Right? What sort of cancers do we see? Look, Kaposi's, one of them reversed with withdrawal of the fingolimod. Merkel cell carcinoma driven specifically by the Merkel cell virus. Right? Pangea from ECTRIMS this year, look at what they're seeing. Lymphoma, lots of skin cancer, vulvar cancer, penile cancer. Right? All HPV or lymphoma. Right? Lots of lymphomas if you look in PubMed. No systematic past study to find out the true rate. Right? That's 4,000 people, roughly over 4 years. Remember I said there's a fair latency of generation of this. Right? The absolute risk of transplant is about 10% lymphoma risk. Right? I don't think it'll be as high with these drugs, but we're going to see a substantial absolute increase. And remember, we're going to be treating for 10 or 15 or 20 years because if you're at ECTRIMS, or my suspicion is that there's no great new drug coming that's going to solve MS for us yet. Last thing I'm going to touch on is the failure of what I call what is called future hazards analysis. So daclizumab, right? Severe DRESS occurred, right? But as far as we know, not cerebral DRESS in the trials. But most patients, only 3% had anything other than an injectable in the trials. But I suspect when it was introduced clinically, right, we saw a fair bit of people being, coming off, say, fingolimod or natalizumab. We knew prior to commercial application of daclizumab that DRESS could affect the brain. And DRESS is in fact a reaction to a virus. It's mostly HHV6, but it can be 7, EBV, CMV, any of the herpes viruses. It's not actually purely a cutaneous reaction. It's an immunological response to a virus upregulated. Right? And so we saw all these disasters with daclizumab, right? But it was not picked up by the EMA. It was picked up by one institute that knew about 5 cases and wrote to the EMA. This is the EMA's document, right, saying that they didn't pick it up themselves. They were told by a German institute. So one institute identified a theme and standard adverse event reporting failed, right? Despite the fact that you could arguably predict that this could happen, and at least it should have been considered as a possible future hazard. And no system was put in place to monitor for it. And so far, 15 cases, most of whom are either dead or have done poorly. Now, that's a plane crash. That's a light commuter plane crash. Now, if a light commuter plane had crashed in Germany, it would have been in the paper, right? This wasn't. So, drug safety in 2018, where do we stand? Historic known adverse events. You get a PI that tells you to do it. Some of you do it. We almost certainly don't do as much of it unless there's a systematic approach such as we've put in place for alemtuzumab with what's called BloodWatch in Australia, LabWatch in the US. That has to be commercially funded. I personally think big red box around adverse event reporting, I think we do it very poorly and we discourage it, and I've said why. Prognostic, I think immunosuppression screens should be used more. I think you should sort of ignore the product information to a certain extent in doing your own class effect, right, for neuroimmunology. And for future hazard analysis, we don't do it at all. Right. And I think the reason for that, right, is that we don't work together. Right? There's no systematic grouping of what's in the best interests of the patients where the regulators, pharma and doctors all get seriously together to plan new drugs. Right? So the practical neurologists are not engaged directly as a broad group other than writing in support of funding a drug when paid to do so, asked to do so by pharma, right, or by the MS Society in the actual regulation. And the regulators are concerned about risk, but they don't really have the people who are well enough informed to know about it. And pharma have their own commercial implications. Right? So I don't think anybody here's at fault. I think the system's at fault. Right? So minimising risks improves the benefit to risk. And the risk of the diseases is still greater, right, than the treatments, we think. Honesty about risks is okay in my experience. The patients know. Okay. Use new systems where you can, or if you're inventing new systems, roll them out in a way that everybody can use them, because it takes a lot of time to build these IT systems, so you might as well. The great advantage of IT is that the scale-up cost is minimal, right? The build cost is there, but the scale-up cost is minimal. The current systems do, I believe, lack integrity. I don't think there's a single group of people who overall are looking systemically at safety and how to do it better. SAE reporting fails. We're passing on the opportunity to really assess long-term 1 in 1,000 risks, such as tumours particularly, and looking at class effects. And we're not doing a future hazards analysis. So just to conclude, sorry, it disappeared off the screen a bit there, but there's a couple of websites. Lots of acknowledgements from my team at what's now called RxMX, and for all skeptics, because I think it's important. And the final acknowledgement's actually my father, right, who is an aviator and taught me a lot, partly just by giving me crash comics to read. The crash comics are the sort of, the black humour of aviation, which is where you read the accidents. And he has had the sort of career that I think we need more of in medicine. So he's done, military flight and then military flight test, civilian flight test. He's done regulator both in Australia when it was fortunately called DOA, Department of Aviation, which wasn't the best acronym. And then also the 380 design program with Airbus, and back doing some civilian flight test. And since I put this slide together, that plane actually crashed. So they were doing some spin trials with some different configurations. They'd hung some pods underneath, and that put it into an irrecoverable spin position. It wouldn't come out of the spin. And then the second layer of defence was a parachute that the plane carries that drags out the back and then straightens it out, and then you can fly away. You release the parachute. That didn't work for some reason. It wouldn't deploy. And so the third line of defence is the parachutes that the pilots carry and jump out. So they're okay. It wasn't my father, it was Dave and one other guy, slightly sore back. So the real point is that there were no patients on board that plane in flight test. So thanks very much.